a big bunch of proactive, prevention-minded, powerful women who want to have accurate and complete information on breast cancer in order to avoid it. I'm Menopause Taylor, the only gynecologist who delivers a comprehensive, unbiased education on everything pertaining to menopause. And currently, we're pursuing a unit on breast cancer. We're in the part of the unit where I present all your management options for preventing breast cancer. This is video number 405, the 50th video in the unit. Can you believe we've spent nearly a year on this? That was necessary in order to correct all your misconceptions about breast cancer and replace them with facts about breast cancer. And if you've been watching all these videos in order, you're at the point of realizing that nearly everything you ever thought you knew about breast cancer was all wrong. Thus far, I've presented options for preventing breast cancer in the categories of diet, lifestyle, exercise, vitamin, mineral, and supplements, and herbs. All of those are categories of options that are readily available and useful for all women. Today, I'm going to present the medication options for preventing breast cancer. And this category is different in that it is not intended for all women. Instead, it is intended for women at very high risk of breast cancer. This is the kind of stuff that is not mainstream. It's on a whole different level. Generally speaking, these are options for women with a genetic mutation for breast cancer, other cancers like ovarian cancer that pose a very high risk of breast cancer, or a high risk based on a risk assessment score. And because this is the kind of topic only appropriate in specific situations and tailored to the specific individual, you will not find this material in my book. This is the kind of thing that warrants a consultation. Videos number 366 through 378 were all on the risk factors for breast cancer. In those videos, you discovered that the list of risk factors for breast cancer is very, very long. Here's the chart of risk factors we created way back then, a long, long time ago. Then, in video number 378, you learned that there are breast cancer risk assessment tools that can calculate your 5-year risk of getting breast cancer and your lifetime risk of getting breast cancer. In addition, there exists genetic testing to determine if you actually carry a genetic mutation for breast cancer. All of these are means via which you can determine whether or not you are at very high risk of breast cancer. And if you are at very high risk of breast cancer, you might choose to pursue options that are more aggressive than the management options I've presented thus far. Remember, everything you do for your menopause management is a matter of weighing benefits against risks. There is nothing that doesn't have to go on the scale that compares benefits to risks. The key is to assign weights as they pertain to you personally. This is true for prevention also. Some means of prevention of a disease are more invasive than others. And the category of medication options for preventing breast cancer is one of them. So this category of options is not for the woman with the average 1 out of 7 risk who just happens to be terrified of breast cancer. That does not warrant enough actual risk to warrant these medications. Why not? Because these medications have risks too. So in order for it to be worth the risks of the medication, your very high risk for the disease has to warrant taking those risks. This is yet another balancing act. On one side of the scale, you place your actual degree of risk for breast cancer. A very high risk for breast cancer could make taking these medications beneficial. On the other side of the scale, you place the risks of these medications for preventing breast cancer. Only if your risk of actually getting breast cancer outweighs the risks of these medications do you consider the options in this category. The most important thing to recognize is that all but one of these medications for preventing breast cancer are actually medications for treating breast cancer. They are all used for only certain types of breast cancer. So using them for prevention means taking an actual chemotherapeutic drug designed to treat only a certain kind of breast cancer when you don't even have any kind of breast cancer. This is called primary prevention. Primary prevention is when you are perfectly healthy and have no hint of breast cancer, but take a medication to prevent ever getting breast cancer. And you take a drug that may or may not prevent the kind of breast cancer that you are most likely to get. And primary prevention is only one level of prevention of breast cancer with medications. It is distinguished from secondary prevention and tertiary prevention. Secondary prevention is when you have breast pre-cancer and you take a medication to prevent the precancer from becoming invasive breast cancer. And tertiary prevention is when you've already had invasive breast cancer and you take a medication to prevent getting it again. So tertiary prevention involves taking a medication to prevent a recurrence of the cancer. And in that case, you know the kind of cancer you had, which enables you to choose the best medication to prevent that kind of cancer. But that is not the case with primary prevention. And we are talking specifically about primary prevention today. We are focusing solely on the situation in which you take a cancer chemotherapeutic treatment drug for purposes of prevention rather than treatment. But all chemotherapeutic medications are notorious for severe side effects. And that's why you would only consider using them for prevention if you have a very high risk of breast cancer. Now, sometimes the dosage of medication for prevention is lower than that used for actual treatment. If that's the case, the likelihood of side effects might be lower, but not always, and they all have side effects. The information I deliver here today will be specific to the chemotherapeutic drugs used specifically for primary prevention of breast cancer. So what are these breast cancer treatment medications that are used for prevention? There are two classes of medications for preventing breast cancer. The selective estrogen receptor modulators, which you probably know as SERMs, and the aromatase inhibitors. So let's delve into these medication options to see what they are and what they can do. The SERMs include tamoxifen, also known as Nolvadex, and raloxifene, also known as Evista. The aromatase inhibitors include anastrozole, also known as Arimidex, letrozole, also known as Femara, and exemestane, also known as Aromatase. These two classes of medications have different ways of preventing breast cancer. In medicine, the term for describing how a medication works is its mechanism of action. So SERMs and aromatase inhibitors have different mechanisms of action. The selective estrogen receptor modulators resemble estrogen. They function by parking in the receptor sites in cells that are reserved for estrogen only. So they prevent estrogen itself from parking in its own parking spot. For breast cancers that are estrogen receptor positive, the SERMs can block any stimulation they might get from estrogen, but only some breast cancers are estrogen receptor positive, and only some breast cancers are stimulated at all by estrogen. So do not assume that these medications can prevent all breast cancers. They cannot. They can only prevent some breast cancers. And if you're using a SERM to prevent primary breast cancer rather than recurrent breast cancer, you have no idea about the hormone status of any possible future breast cancer. So you could take the medication and still get a different kind of breast cancer. This is a very different situation from tertiary prevention, in which you've already had a breast cancer for which you know the hormone status, and you know the medication that's the right one for treating or preventing it. The aromatase inhibitors function in a completely different way. In other words, they have a completely different mechanism of action. Aromatase is the name of an enzyme that converts androgens to estrogens in your fat tissue, your liver, and your muscle. And aromatase inhibitors block the last step in conversion of androgens to estrogens in these distant sites. So both of these two classes of drugs block stimulation or action of estrogen, but they do so at different sites. SERMs block estrogen at the receptor site parking spot, while aromatase inhibitors block estrogen at a distant site. Notice also that both classes of medications only target breast cancers that are stimulated by estrogen. They cannot prevent the many, many types of breast cancers that are not stimulated by estrogen. Now, if you've been watching my videos in order, you should be saying, what? Why in the world would all the medication options for preventing breast cancer target estrogen when estrogen does not cause breast cancer and isn't even on the list of risk factors for breast cancer? Well, it's because almost 80% of breast cancers are estrogen receptor positive. And when you think about what I've taught you about how your breasts respond to the stimulation of estrogen and progesterone, that should not come as a surprise. But remember, if you're talking only about primary prevention as we are today, taking a chemotherapeutic drug that targets estrogen when you don't have breast cancer or know if you'll have an estrogen receptor positive breast cancer if you do get it is quite an assumption. Whether you choose to take a SERM versus an aromatase inhibitor depends on a variety of things. And as usual, there are trade-offs between them. So let's address each of these medications one at a time. The first one is tamoxifen or Nolvadex. Tamoxifen has been around for over 30 years. It is for both premenopausal women and postmenopausal women. It is useful for preventing breast cancers that are estrogen receptor positive. And it can decrease your risk of that particular kind of breast cancer by 50%. The big trade-off with tamoxifen is that it causes an increased risk of endometrial uterine cancer blood clots in the form of deep venous thrombosis, or DVTs, and stroke. And it has the side effects of causing cataracts and muscle cramps. For purposes of breast cancer prevention, you take it for only 5 years. It offers no benefit beyond 5 years. The other SERM for prevention of breast cancer is raloxifene, or Evista. Like tamoxifen, raloxifene is for both premenopausal women and postmenopausal women. And like tamoxifen, it is useful for preventing breast cancers that are estrogen receptor positive. Another similarity to tamoxifen is that it decreases your risk of estrogen receptor positive breast cancer by 50%. You may recognize raloxifene as one of the medication options I presented in the unit on osteoporosis. And that's because it was first developed for the treatment of osteoporosis. Only later was it discovered to have the benefit of preventing breast cancer too. The two benefits raloxifene has over tamoxifen is that raloxifene does not cause endometrial uterine cancer or cataracts, but it does increase your risk for deep venous thrombosis, or DVTs, and stroke, just like tamoxifen does. And the typical duration of raloxifene therapy for purposes of preventing breast cancer is 3 years. It has no benefit beyond 3 years. Of all 5 of the medications we're addressing today, raloxifene is the only one that is not an actual chemotherapeutic agent for treatment of breast cancer. So depending on your particular situation, you may prefer one SERM over another. If you still have your uterus, you might be better off choosing raloxifene, since it doesn't increase your risk of endometrial uterine cancer. Now we turn our attention to the aromatase inhibitors. They are anastrozole, or Aromatase, letrozole, or Femara, and exemestane, or Aromatase. Aromatase inhibitors are approved for only postmenopausal women. This is because their mechanism of action is to block conversion of androgens to estrogens. And premenopausal women produce too much estrogen for this to have any impact. In contrast, postmenopausal women have estrogen levels of 0. So the estrogen converted from androgens in their fat, liver, and muscle is really the only estrogen they have. And unlike the SERMs, aromatase inhibitors can prevent both estrogen receptor positive and estrogen receptor negative breast cancers. This is why they are being used more than the SERMs these days. But that still does not cover all types of breast cancer. Because as much as everybody wants to focus on estrogen, the majority of breast cancers are not stimulated by estrogen at all, even the ones that are estrogen receptor positive. So let's talk a bit about each of these 3 aromatase inhibitors. Anastrozole, or Aromatase, was initially approved for treating advanced or metastatic breast cancer, but it was found to be capable of preventing breast cancer too. And it was found to be generally comparable to tamoxifen for prevention. But it is more effective than tamoxifen in preventing a new primary breast cancer in the opposite breast for women who have already had breast cancer. So this would constitute tertiary prevention. The common side effects of anastrozole are hot flashes, body pain, dilation of blood vessels, nausea, and bone fractures. And the optimal duration of use for purposes of preventing breast cancer is yet unknown. The next aromatase inhibitor is letrozole. It was also originally approved for treatment of advanced or metastatic breast cancer and only later found to be generally comparable to tamoxifen for primary prevention. Like anastrozole, it is more effective than tamoxifen for preventing breast cancer in the opposite breast of a woman with a history of breast cancer. So its most beneficial use is for tertiary prevention, not primary prevention too. And like anastrozole, it increases your risk of bone fractures. Its side effects are hot flashes, bone pain, back pain, joint pain, nausea, and shortness of breath. The duration of therapy for purposes of breast cancer prevention is 5 years with no benefit after that. The third aromatase inhibitor is exemestane. And this one is approved for advanced breast cancer that has not responded to other chemotherapeutic agents. Still, it is used for prevention also, typically for 5 years. The side effects of exemestane include hot flashes, nausea, excessive sweating, and its risk is that it imposes an increased risk of bone fractures also. So the biggest differences in these medication options for preventing breast cancer are that the SERMs, tamoxifen and raloxifene, are only for estrogen receptor positive breast cancer prevention. Tamoxifen and raloxifene are the only two suitable for pre-menopausal women. Tamoxifen causes endometrial uterine cancer, and the aromatase inhibitors cause bone fractures. You probably know me well enough to realize that options like this conjure up all sorts of questions in my mind. And they should do the same for you too. So let me just pose some of the questions that are going through my mind and that you might want to consider. The first thing that comes to my mind when I look at these medication options for preventing breast cancer is that they all have a designated duration for use. In other words, you take them for only a designated number of years, typically 3 to 5 years. So the question in my mind is, then what? And the reason I pose that question is because of what I've taught you about so many medications for various things. Most only work while you are taking them. When or if you stop them, you stop gaining the benefits they offered. This is true of estrogen replacement itself and all the bone-building medications. Raloxifene is one of the bone-building medications for which this principle is true. So when it comes to preventing breast cancer, is your goal to prevent it for just 3 to 5 years? Or is your goal to prevent it forever? I find this bothersome because the side effects and risks of these medications are significant. And in deciding whether or not to take them, you have to balance benefits against risks. If the benefit is lifelong, it weighs more than if it's only short term. But if the benefit lasts only while you're taking these chemotherapies, is it worth the side effects and risks? With everything you consider for any aspect of your menopause management, the most important thing of all is to weigh the benefits against the risks as they pertain to you personally. The second question that comes to mind is, What if you take one of these drugs for primary prevention of breast cancer, but end up getting breast cancer anyway? Will the fact that you already took one of these drugs limit your treatment options of the actual cancer? Will you be barred from using the proper drug for the real thing? Could it be a matter of putting the cart before the horse, or in this case, the drug before the disease? The third question that comes to mind is, shouldn't we differentiate between a primary purpose of a medication and a perk of a medication? For instance, raloxifene, or Avista, is primarily for purposes of bone building. It's one thing to use it primarily to build bone and decrease your risk of fractures, and also decrease your risk of breast cancer as a perk. But it's another thing to use it for the primary purpose of preventing breast cancer. Another term for this is off-label use. Off-label use is when you use a medication for a purpose other than its designated purpose. And I've taught you about it before. There's nothing wrong with off-label use, but we're talking about using cancer chemotherapeutic drugs for purposes other than their designated purpose. So this carries more risk than usual. If you endure the risks of these drugs to actually treat cancer, that might be a beneficial thing. But if you endure the risks of these drugs to prevent a cancer, that's an entirely different thing. The fourth question that comes to mind is, would you have radiation therapy as a means of primary prevention if you didn't have cancer? Would that make sense to you? Would it be worth the risk to you? If not, what makes chemotherapy a more reasonable option? Both involve killing healthy cells with a treatment modality designed to kill cancer cells. What makes one option okay and not the other? The fifth question that comes to mind is, how much more can these chemotherapy drugs decrease your risk of breast cancer compared to the diet and lifestyle measures I presented in previous videos? Is it worth the risk of taking these drugs? With people wanting quick fixes for everything these days, you have to step back and really wonder about this. Diet and lifestyle measures for preventing breast cancer are things you can do for a lifetime, which is a big benefit with zero risk. These medications are things you can only take for 3 to 5 years, which is not a big benefit, but it is a big risk. Which do you think gives you more protection from breast cancer in the long run? The chemotherapy or the lifestyle? The sixth question that comes to mind is, are cancer chemotherapies a means of primary prevention for other cancers? Some men take cancer chemotherapeutic agents as tertiary prevention of prostate cancer, but they've already had prostate cancer. Chemo prevention for colon cancer includes aspirin and non-steroidal anti-inflammatory drugs. And those are a far cry from cancer chemotherapy drugs. But I know of no other cancer for which people take actual cancer chemotherapeutic drugs for primary prevention. Isn't that odd? Or could it be that such is the case for breast cancer, all because of fear? Are women so so afraid of breast cancer that they will actually subject themselves to breast cancer chemotherapy when they don't even have breast cancer? Or could it be that there's big money in marketing cancer chemotherapy drugs for prevention of breast cancer simply because women are so afraid of it? These drugs are not inexpensive. There is a lot of monetary gain involved. The second question that comes to mind is, how do you assess the success of these drugs in terms of primary prevention? What if the women using them never would have gotten breast cancer in the first place? Is peace of mind a measure of success? Does taking a cancer chemotherapeutic agent to prevent primary cancer give a woman a false sense of security? And the eighth question that comes to mind is the risk of taking these medications greater or less than the surgical means of prevention that I'll address in the next video? Have you noticed that I just ask questions? I do not provide the answers. You get to provide your own answers. I know, I know. I'm completely worthless. Asking questions is so powerful for really finding the logic or illogic in things. I find that most people don't ask enough questions. Instead, they're merely gullible. They believe what others tell them to believe. Please ask questions. Do not settle for things that do not make sense. That's the power of a real education. So the summary today is a chart of these medication options for preventing breast cancer, along with all their similarities and differences. Now, don't let all these colors overwhelm you. All I have done here is list the 5 medication options for preventing breast cancer along the top row. And in the first column, I've designated the factors that we delineated for each. These include primary use, mechanism of action, duration of use, menopausal status, uses for which kinds of breast cancer prevention, other benefits, limitations, risks, and side effects. The color coding just helps you see the similarities or differences between them, with similarities in the same color and differences in different colors. This chart is available in the description box by clicking on the link, and alternatively, you can go directly to menopausetailor.me to get as many charts as you want, and you can also schedule a consultation for anything you want while you're there. And next week, we'll address our final option for preventing breast cancer, which are the surgical options. Go back and re-watch some videos in the meantime. You will be shocked at how much more you learn the second time you watch them. Be sure to subscribe to everything if you haven't already. That means to this channel, to my newsletters, and be sure to find me on Facebook, Instagram, Pinterest, and Stories if you haven't already. Okay,